Hi, my name is Rose, and I'm here to discuss Chapter 34, Drugs for Immune System Modulation. So in order to speak about our subject today, I would like to make a brief explanation about the immune system. Our immune system is in our body to protect our body from any pathogens, such as bacteria and viruses. And our first line of defense is our innate body defenses, which are general to our skin, the inner lining of our lungs, and the inner lining of our stomachs. But more specific, we have our adaptive body defenses or immune response, which are our lymphocytes, phagocytes, that target specific threats to our body. And if our body, let's say, cannot handle these threats, we would be using immunomodulators, which is what our chapter is regarding. And they either stimulate or suppress our immunity. So a large number of chemical messengers interact in our immune response. And two primary divisions of our immune response are antibody-mediated humoral immunity and cell-mediated immunity. So that's when I go to our next presenter.
My name is Jocelyn, and today we'll be covering Chapter 34.2, Humoral Immune Response and Antibiotics. The first term we have here is humoral immune responses. This is initiated when an antigen encounters a type of lymphocyte known as the B cell. The B cell becomes activated and then it divides rapidly throughout the body, forming clones and copies of itself. One of the clones it forms is called plasma cells, and these plasma cells secrete the antibodies specific to the antigen that initiated the challenge. Circulating throughout the bodies, we have the antibody, which is an immunoglobulin, also called Ig, which physically interacts with the antigens to neutralize or mark them for destruction by other cells of the immune response. After the antigen is challenged, we have some cells called the memory B cells. They are formed that will remember the specific antigen-antibody interaction.
Hello class, my name is Javier Araque, and I will be covering chapter 34.3, and it's going to be administering vaccines. So, as we all experienced for clinicals, they were not fun, and they were not cheap. So, does not take away from the fact that they're very essential to our body, okay? A vaccination or also immunization is a process of us putting foreign proteins or inactive cells into the body so they can trigger immune activation, but it's important to do it before you're actually sick, because once you're sick, then it will have no effect. The point of an immunization is actually to destroy a pathogen. Julian, what's a pathogen? Great question. A pathogen is anything that can cause disease, okay? And the important part is to get it over with. Now, we're gonna turn this guy's frown upside down. This guy has a virus. What's not a virus? He has a bacteria, or he has something that's gonna require a vaccine, right? So in order to turn his frown upside down, we're gonna have to give him a shot. Some of the shots that we've received, for example, are influenza. We received the Hep A, the Hep B vaccines. The point of them is to create B cells, and then what they do is they actually, they bind to the antigen and they produce antibodies to help destroy the pathogens. So our goal is to destroy pathogens. Now, some immunizations we only get once, but then some require a booster in order to continue the lifelong immunity to the actual virus itself or the bacteria. Sometimes we get titers, and then what they do is they're going to measure the effectiveness assessed by the shot itself, and it's gonna measure the amount of antibody produced in the vaccine. So that's what we call titer. What's the goal of a vaccine is to, like I mentioned, is to induce long-lasting immunity to a pathogen without producing illness in an otherwise healthy person. That's the first cut. The next part that I will be covering will be the 4 methods of producing safe and effective vaccines. As you can see, I have written all 4 down. The first one is going to be attenuated, and those are the ones that contain microbes that are alive, but they're weakened. That way they're unable to produce disease unless the patient is immunocompromised. So patients that have an impaired immune system, somebody who has cancer, somebody who's pregnant, you do not want to give them, major key, do not want to give them these vaccines because it will compromise their health. Usually somebody who's pregnant, what you can do is you would give them the vaccine after delivery. That way you do not potentially harm the fetus. Some examples of those are going to be measles, mumps, and rubella. The second time is going to be inactivated, and those are going to be vaccines that contain microbes that are going to be inactivated by heat or chemicals, and those are they're unable to replicate or produce disease. Boosters may be necessary to prolong the immunity, and those are the ones that we recently actually got, the influenza, for some people who need the Hep A vaccine, or the human papillomavirus, aka HPV. The third one is going to be the toxoid vaccine, and these contain toxins that may be chemically modified to be incapable of causing disease, and the main example for that one is going to be tetanus. The fourth type is going to be recombinant, and these are technology-based vaccines, and they contain partial organism or bacterial proteins that are generated in a lab using technology, and an example of that would be the hepatitis B vaccine. The next section is going to be the two types of responses due to vaccines. One is going to be active immunity, and the other one is going to be passive immunity. They're not very difficult to understand, so I'm going to put it in the easiest way. An active response is a response that's induced by a real pathogen or its vaccine. So if somebody gives you a vaccine, that's called active immunity. Passive immunity, on the other hand, is something that's passed on from one person to another. So from a mom to a baby, through breastfeeding, through birth, is the way that you get passive immunity, okay? Just to summarize, administering vaccines, we're gonna go over some key points. The first one, like we mentioned earlier, the main goal for vaccines is to prevent illness. Then, vaccines can produce adverse effects. So if it's something that happens to you through a flu shot or I don't know, a Hep A shot or a Hep B shot, make sure that you contact your physician. Make sure you visit the doctor as well if you have any adverse or serious side effects. The next one is a very important stat that shows in the book. Most mortality from vaccine preventable diseases in adults are from influenza or pneumococcal disease. And then the last one is anybody who's at risk could be women who are pregnant, people who have diabetes, people who suffer of heart failure or renal kidney failure. And that's going to do it for administering vaccines.
Hello, my name is Danielle, and today I'll be explaining cell mediated T cells and cytokines. So basically what starts off, it's an antigen. It goes to the macrophage to where the T cells kick in. So you could think of a T cell kind of like as an alarm. It will alert the B cells what's going on, and it will tell the cytotoxic T cells what's going on. What cytotoxic T cells do is they will help to kill the substances, the foreign substances, and they'll act upon the antigens. But they don't produce antibodies. So that's where cytokines will come in. Cytokines, what they'll do is they'll regulate the intensity and the duration of the immune response from the T cells that activated it, and it'll mediate cell-to-cell communication. So what it'll do, it will help the cells that are communicating to tell each other when to produce this and when to produce that. So also, they'll either kill the substances or sometimes they'll even produce inflammation to stop that. So T cells don't just end there. They, after the antigen is dealt with, T cells become memory cells. So there's helper T memory cells and there's cytotoxic T memory cells. What the helper T memory cells do is it'll basically alert the body quicker, and it'll already know what that antigen is, and it'll let the other T cells and other B cells know when to kick in. So the cytotoxic T memory cells will have already dealt with that specific antigen, and they'll be able to take care of it quicker. And that's the summary on cell-mediated response, T cells and cytokines.
Good morning, cohort 27. How you doing? My name is Julian, and I've got a real treat for you guys here today. Today we're going to be discussing immunostimulants. Does anybody know what an immunostimulant is or have any idea what it does? No, let me break it down to you. An immunostimulant is anything that can stimulate an immunoresponse. Does anybody have any idea why we would use that? Like, why would we want to do that?
No.
No? Well, an immunostimulant is similar to a positive loop response. So it's obviously something that we don't want to mess with too much, but sometimes it's necessary. Immunostimulants target the innate immune system, which we are born with from day one. The other immune system is the adaptive immune system, which we evolve over time. Vaccines and whatnot are what give us our memory there. Now, this idea of immunostimulation and getting the body to defend itself isn't actually a new idea. It's an old idea that was taken back in the day of smallpox and stuff, where they used to crush the smallpox scabs and snort them to give people immunity. Nowadays, though, that we have better technology through recombinant DNA technology, we've learned that we can take genes from this animal and genes from humans or another animal, put them together, and we get these immunostimulants, right? The key to immunostimulation is the cytokines. Cytokines are cell signaling molecules that are responsible for cell-to-cell communication during an immune response. Very simple. What this means is, if you look over here, during the infection, you get these pathogens. This can be anything from a bacteria, a virus, you name it. In the blood, we have these macrophages that are alerted to any invading pathogen. What happens is, as these guys fight, the macrophage is sensing that this is going to be a big thing. They call in the neutrophils, okay? And they do this with these little chemical messengers that are our cytokines, okay? Now, these neutrophils are like King Leonidas in the movie 300. You know, I am Sparta kicking people. So you don't want these guys running around too much, because these guys, they kill healthy cells too. And what these cytokines do after they've been treated with an immunostimulant is they bind to healthy cells. Like, let's say over here we got these little healthy cells that these infection cells want to attack. And what the cytokines do is they warn of the incoming infection, so that these cells can secrete proteins, antiviral proteins, that will protect them and will inactivate the virus should it latch on, okay? Some of the things we use immunostimulants for is, for example, we have interferons, okay, which is a class of immunostimulants, and these are secreted by lymphocytes, macrophages. They can't, like I said before, they can't protect themselves, so what they do is they bind onto other cells to warn of the incoming attack. And they have a way of increasing phagocytosis and enhancing the cytotoxic ability of killer T cells and neutrophils. So what you have to watch out for when you're using an interferon is that you have too much of an immune response, kind of like anaphylaxis. Your body will start killing itself. The other phase that you have is the interleukins. Now, these interleukins, they're a little bit different in how they work. They are also secreted by lymphocytes, monocytes, and macrophages. But what they do is they stimulate T killer cells, predominantly in attacking tumors. And they also stimulate a fast replication of B and plasma cells, which actually help with hemopoiesis and stuff like that, which recovering blood cells, a greater production of red blood cells, white blood cells, and platelets. Now, scientists figured out that by targeting the innate immune system with an immunostimulant was the best plan of action, because you'd have to manage the reaction to keep it within means, so you just didn't go on a positive loop and kill the organism. But you also gained adaptive immunity along with it. So it was like it was like kill two birds with one stone. The IFNs, or the interferons, we typically use them with hairy cell leukemia, age-related sarcoma, non-Hodgkin's lymphoma, malignant melanoma, and chronic hepatitis, virus B and C. They've shown to be very helpful. IFN beta, which is another kind, we use to treat multiple sclerosis. And the IFN gamma, we use only really to treat severe osteoporosis and granulomatous disease. The interleukins, we treat a lot of kidney cancers, metastatic melanoma, because of the activated B lymphocytes and plasma cells. They help a lot there. And the other one is interleukin 11, which we use for HIV, AIDS, and people with an immunosuppressed system, something that's defective, deficient, because it helps stimulate and produce red blood cells, white blood cells, platelets, and so forth and so forth. So that's why it would help there. You definitely don't want neonates or children, young babies, to have this. Also, if your patient is has severe liver issues, you don't want them to use it too, because this is extremely liver toxic. Just to give you an example, interleukins, you're gonna have flu-like symptoms and stuff like that. Those are the manageable symptoms. But you can also have cardiac arrest, hypotension, tachycardia, thrombocytopenia, anuria, pulmonary embolism, and something called capillary leak syndrome and sepsis. Capillary leak syndrome is when the chemical, the cytokines and all that stuff actually start leaking through the capillaries into the surrounding tissues, and ultimately you end up with sepsis. Interferons, you have a lot of also flu-like symptoms. You have thrombocytopenia, leukopenia, anemia, suicidal ideation, severe depression, seizures. So these are all things that as a nurse you have to be cognizant of. So the biggest things here in the nursing care process is making sure that your patient understands what he's doing and the risk versus the reward. A lot of these patients that are going to be taking these kinds of medications are desperate. So they're going to latch on to anything. So you really have to talk with your patient and make sure that your patient understands the risk versus reward, and if this is indeed for them. You have to be the patient advocate. You also have to remember that during the administration phase of this medication and your assessment phase, during therapy, you have to really pay attention, because these patients can deteriorate very quickly and into life-threatening situations. So you have to be prepared to administer interventions. You have to be prepared for things to go south, and you have to manage things as best as you can. And that'll be it for me. Do you guys have any questions?
No.
Thank you.
Okay, I'm going to cover chapter 34.6. This section of the chapter is talking about immunosuppressants. Immunosuppressants are drugs, obviously, that dampen the body's natural immune response or suppress it. It seems to maybe not make sense. Why would we want to suppress somebody's natural immune response? Well, there's a few instances where we need our immune system to be suppressed or less active. One of these uses is going to be when you have a transplant. So if you have an organ transplanted, obviously they're going to do careful tissue typing, matching, get the best, closest match to your own cells. But they're still gonna have antigens on them that don't match your own body. So by giving immunosuppressants, first of all, immediately after, you can prevent your body from rejecting these foreign organs. If you don't provide immunosuppressants, the body can destroy organ tissue within just a few days. And even if the body doesn't immediately reject an organ, it can actually happen weeks, months, or even years later. So initially, they're gonna take the strongest immunosuppressants, and some organ transplant patients are gonna be on some type of immunosuppressant pretty much chronically for the rest of their life. So sometimes you take them immediately, sometimes you take them long-term, sometimes both. Another reason why we might want to dampen someone's immune response is if their immune response is naturally too high. You're gonna see this in cases of inflammation, especially in autoimmune disorders. So what are some autoimmune disorders where your immune system doesn't work properly? Your immune system attacks your own cells. It's gonna be things like MS, Hashimoto's, which is a thyroid disease, psoriasis, which is a disorder of the skin, is gonna be one of them. Let's see. Also, one that we commonly treat with immunosuppressants is gonna be lupus. And then another one is rheumatoid arthritis. So when you're treating these autoimmune disorders, it's a little bit different than with transplant rejection. Usually you're gonna give a really high dose of the immunosuppressant for a short period. This is going to prevent relapses or flares where the autoimmune disorder is at its highest point of attacking your natural system. If these drugs are used for a long period with these diseases, it's usually going to be in lower dosages, and this is considered for maintenance or prophylaxis, so preventing those flares from happening. And then what kind of drugs do we use for immunosuppressants? There's a few different categories. The one that everyone probably knows and maybe has taken before is going to be glucocorticoids. These are your steroids. These treat inflammation, but more short term, so it's not fully covered in this particular chapter, but this is going to be like prednisone. It can be used even for like respiratory short-term illnesses, things like that. Now, for your autoimmune disorders and your transplant rejection, there's a couple of other categories that you're going to fall into. One of them is antimetabolites. Antimetabolites work by inhibiting lymphocyte replication. One of the common drugs used in this category is called sirolimus. This is the drug that they would commonly administer directly after your transplant. And another category that they would use is calcineurin inhibitors. And in this category, we have one of our prodrugs or prototype drugs. It's called cyclosporine. And what calcineurin inhibitors do is they disrupt the T cell function in the immune system. And these can be used for all of these disorders, including psoriasis, which seems like, pretty minor disorder, but it is treated using a calcineurin inhibitor. Anyway, so this is just a brief overview of immunosuppressants. Glucocorticoids are covered in another chapter, but that's just an example. These are the main categories covered in this chapter.